Welcome back. We've been talking a little bit about colon cancer and hopefully getting into diverticulosis as well as answering a few other questions from our astute audience. And I love their questions. They've been very good. And really, there's no question that's too stupid. I've never had one yet. It's something you're concerned about. Please feel free to call in. And I will do my best to answer it. And Ray always has very good questions, and we'll certainly try and figure out his new treatment, and maybe I can put some slides up regarding that. Anyway, again, don't think that just because you don't have a family history of colon cancer that you can't get colon cancer, and it's a very important. It ranks up probably in the top 5 of the causes of all-cause mortality, and it's a shame because it really can be prevented. The cancer chemotherapy for colon cancer is not very good because it is not usually a rapidly dividing tumor, and it is very slow growing usually. So that means, and I think with regards to chemotherapy, the faster the tumor is, the more aggressive it is. Usually it may incorporate some of those hard chemicals into it and destroy that tissue. That being said, we want to get into the topic of diverticulosis. Now, diverticulosis is the reason I mention it with colon cancer is, as one of my slides will show, that is a cause for bleeding. And because people will bleed from their rectum, hemorrhoids are one of the causes for bleeding. But here's the thing about rectal bleeding. When you bleed from your rectum, a lot of people say, oh, it could be hemorrhoids. Well, that is certainly true. But just because you have hemorrhoids or have had hemorrhoids in the past doesn't mean that you don't have a lesion or some reason up higher that's causing that bleeding. Black tarry stools or melena are usually upper GI bleeds, meaning they've had a chance to be affected by the enzymes and the digestive material in our gut, and that turns a very foul-smelling black tarry issue. That is usually not how colon cancer presents, and rectal cancer can be bleeding, but it's in the same line as colon cancer. So just because you've had a hemorrhoid in the past doesn't mean that that bleeding is due to the hemorrhoid. You have to get that checked out. You have to think of it as colon cancer until proven otherwise. But as our colon ages, it becomes a little weaker. And I think we can bring up that first slide about diverticulosis, and it's diverticular disease. And to develop that diverticuli, you really need to have a weakness. I mean, you have to develop diverticuli before you can actually get diverticulitis, and I'll try and explain the difference between the two. But what they are is, as our colon is fed in blood vessels, it's fed from the outside in. And similar as to our heart muscle, it doesn't get the blood from the inside in our heart, it gets it from the outside. So these blood vessels are going down the side and they go through the tissue wall. And as the muscularis portion of the colon weakens over time, you might potentially get an outpocketing of that wall called a diverticuli. And they're more common in the sigmoid colon because of the increased pressure. So if you're one that has to strain to go to the bowel movement and things of that nature, you're increasing the pressure in that area that could somehow involve other problems. And like I said, it's uncommon before the age of 40. I've seen a couple people with it at early ages, and it is pretty, like I said, it's pretty unusual. Those people are going to have a lot of issues down the road. But that being said, first you have to have the diverticuli before you can develop diverticular disease. And remember, diverticuli and diverticuli is basically multiple. Diverticula is a single outpocketing of the colon. Okay, we got another slide, and the risk factors again were increasing in your age. Constipation again is a risk factor because of the pressure developed in the sigmoid colon, which is the end of the colon. And basically what they call a dietary that's low in fiber, that's been somewhat questioned, as a recent study said that maybe it might be just the opposite of that. But that being said, if you're constipated, and one of the things that happens in a dietary fiber, that a diet that's low in dietary fiber, is constipation, and that could be a risk factor. There are some connective tissue diseases such as Marfan syndrome and Ehlers-Danlos syndrome, and I don't know if anybody knows that, but Abraham Lincoln had Marfan syndrome. And those can cause that. And if you have hereditary disposition, if it's in your family, then those are certainly risk factors for that disease. So again, basically as that blood vessel goes on the outside and it comes through the wall, and that creates this weak spot in our colon where it can be pushed out. If those become irritated, the diverticuli or diverticula, if it gets irritated, can bleed, and that would cause bright red blood in your rectum or in your stool, as opposed to basically a little bit of a hemorrhoidal bleed. And I think you need to understand that rectal bleeding is really a medical emergency. It's really one of those things that can kill you if you're not very careful about it. I think we have John on the phone. John?
Yeah, doctor, how you doing? Just happened to tune into your show tonight. And I went through a series of, since we're talking GI issues, I went through a series of tests last year. And thought I had Crohn's disease. Come to find out after all these series of tests and examinations, I really have antral erosive gastritis in the lower part of my stomach. And I've been dealing with this for about 5 years. I've really radically changed my diet to accommodate that. But the way to kind of keep it under control, the main question I have for you tonight, the way to keep it under control is with these proton pump inhibitors to reduce the acid in the stomach. What is the risk factor in taking those long-term, like, say, 4 or 5 months at a time straight?
Okay, well, that's a good question, John. It used to be believed that there was a study when Prilosec hit the market that there was a risk factor of developing some type of cancers of the gastrointestinal tract, and that since has been eradicated because of the doses they gave the mice was some super high dose, and that didn't pan out to be the case. I think one of the being risk factors of proton pump inhibitors is that you don't make enough acid in your stomach. So therefore, with that being said, you're going to sometimes maybe not digest. If you're eating raw foods or healthier foods, you may be at higher risk of developing some bacterial infections and other infections that you normally might not get. So that might be one consideration. Make sure your food is prepared extremely well and cooked very well so that you reduce the risk of bacterial, because the acid usually kills most bacteria in our stomach and aids in digestion. The other risk factor for long-term proton pump inhibitors is the malabsorption of certain types of calcium supplements. So if you're taking calcium carbonate, you will not absorb that, and osteoporosis might be a risk issue. So you have to take calcium citrate products to help to do that. Also, there's the risk of interference of these particular products in the cytochrome P450 system, which is the liver's mechanism of degrading these particular products. And they have a new genetic test for those over age 65 that can identify if you are how you metabolize Prilosec and things of that nature. A lot of people are on Prilosec and drugs like Plavix. Well, Prilosec reduces the effectiveness of Plavix. So if you've had a vascular procedure or a stent and you're on both of those drugs, you could be taking Plavix and it could not be as effective as it could be. Those are really the main issues that I see doing that. Obviously, the benefits are reducing gastric irritation, reducing the risk of inflammation, and if we continue to have inflammation in our body, then we will possibly develop transitional cells, which will transition. The body responds to stress by making new types of tissue, and that process is called metaplasia, meaning we go from a one particular tissue type to another in response to stress, and that sometimes can induce cancer changes. So taking these proton pump inhibitors and reducing the acid might be a benefit in reducing some types of lower esophageal cancers. Obviously, Barrett's disease, scarring of the esophagus, dysphagia, difficulty in swallowing, eating are also benefits that might be prevented as a result of taking these medications. And you said something very important about 3 or 4 months or 5 months at a time, and then taking a drug holiday. Those are very important issues in remembering that if you can take a drug holiday, even if you were to do it at 3 or 4 days and then off 2 or 3 days, you would give your body a chance to reaccumulate and never be on the medication. There's probably a little bit of risk of you basically maybe not getting your symptoms treated. So if you have something like that, I would encourage you to keep regular appointments with the GI doctor for scopes, because you're going to reduce acid irritation and you're probably not going to get things checked out because you're going to feel comfortable. So that could be a downside to taking proton pump inhibitors for a long period of time, is that a disease process is developing for which you're not having any symptoms, and therefore you're not getting it checked out. So make sure you do keep up with your gastroenterologist so that he can continue to scope your stomach and make sure that you're not developing any side effects of long-term proton pump inhibitors or any other processes. Okay, it was a very good question, and we're going to take another break, and then we'll be back for the last segment of the show. Thank you for tuning in tonight.